Welcome to the American College of Obstetricians and Gynecologists Video History Project. Today we're extremely happy that we're able to interview past President Dr. James Breeden. James, thank you very much. And I'm going to call you Jim because I've never called you James before.
Sounds foreign to me too.
Let's get a little bit background about you, who you are. Tell me, where were you born?
I was born in Milwaukee, Wisconsin, St. Luke's Hospital.
And you went to, for your first schools were in Wisconsin?
In Wisconsin, I was born and raised in Milwaukee. I attended Catholic high school, grade school, and then Marquette High School, which is a college preparatory school, and then went to Marquette University, and then at that time was Marquette Medical School, and then became the University of Wisconsin Medical School.
Why did you decide to go to medical school?
It seemed exciting. It seemed to be it was certainly the top pinnacle for academics at that point in time. The smartest people were going into medicine, and I kind of thought that I might belong in that field. And so it seemed interesting, and the more I learned about it, the more interesting it seemed. And so that's the path I took.
Did you decide to go to Marquette automatically, or did you just look at other medical schools?
No, I looked at other medical schools. I came from a very poor family, and I was working to get myself through college, and so I actually, I don't have an undergraduate degree. I never graduated from Marquette University. I went into medical school after 3 years. And I had been accepted by the University of Pennsylvania, but I was engaged at the time to my lovely wife of almost 52 years now, and she had one more year to go to get her degree. And so I really wanted to stay in Milwaukee, so I went and talked to them, and they said, we don't take third-year students, never have, never will. And I kept talking, and they made an exception, so I ended up going to Marquette.
When you were in medical school, why did you decide you wanted to go into OB?
I was going to be a surgeon. I was going to be a general surgeon. And then the first rotations I did on general surgery, I don't know if it was all programs, but that program, they were especially nasty people. They were just throwing instruments, demeaning people, and I said, this just isn't me. I don't belong here. And then I did my OBGYN rotation, and I loved surgery. I thought that was great. I was pretty good with my hands, and I said, man, gynecologists do surgery too. And it's quicker. It doesn't take as long. So that was kind of the interest I had, that it was a surgical specialty. Plus, I found I loved delivering babies. It was really a lot of fun. And I had just finished a rotation at Milwaukee Children's Hospital, where at that time we had a lot of terminal small children. And I said, psychically, I don't think I could deal with children dying on me all the time. So I thought OBGYN was the best one, and it certainly turned out to fill all my expectations.
And where did you take your residency?
I went to San Diego. Being born and raised in Wisconsin, I thought a warm climate might be nice. So I went to San Diego. And I had gone out there and done an externship between my junior and senior year, and I had checked out a couple hospitals. And I really knew that I wanted to be an OBGYN, and so I was looking for a program that had a straight OBGYN internship, and they had just started one at Mercy University Hospital program, and so that's where I went. And so I was the first group that did a straight OBGYN internship, which was very interesting because being there when the next year of residents came in, I was a first year resident, all the staff kind of thought of me as a second year resident because I'd already been there, and by the time I was the senior resident, I was considered staff pretty much. So I got certainly a lot of volume and a lot of good teaching. It was a good program.
When you finished the program, what was your first post-residency position?
The United States Navy in Port Hueneme, California. I was the last of the doctor group to get drafted at the end of the Vietnam War, and they didn't really need me, fortunately, in Vietnam, so they put me in a small temporary wooden structure that was built in 1944 that was still a little hospital up there, and it was a CB base. And so we took care of the dependents there and the active duty people.
Were you the only OBGYN there?
No, there were three of us. The Navy, in its infinite wisdom, put three of us there, all of us just finishing our residency. So nobody with any really senior status or extra, rank or anything like that. So we made it happen. I was very happy to be trained as well as I was, because the first weekend I was on call, I needed to do a cesarean section, and I asked them to call anesthesia, and they told me they didn't have anesthesia on weekends. So fortunately, where I trained, we did our own spinals and epidurals, so I put in a spinal and did the cesarean section. But going from the 12-story in-house, every subspecialist and specialist you can think of, to being the only physician in the room. I had a corpsman helping me with surgery, a corpsman helping me take care of the baby. We didn't have a pediatrician, I found out, either. And a corpsman helping me with anesthesia. And that's when you're real happy you're well trained.
And where did you go after the Navy?
After the Navy, I went to Carson City, and I'm still there. So,
why did you pick Carson City?
If it hadn't been for the Navy, I'd still be in San Diego. I was offered a position with one of the private practices in San Diego, and it was the man that obviously we respected very much because he delivered both of our children. And he offered me a position, and I was really excited to accept it, and then I got drafted unexpectedly. And because of that, he couldn't hold the position for 2 years. And so when I started looking back to go back to San Diego after my first year in the Navy, the offers I was getting were from people that I knew, and I knew I really didn't want to work with them for varying reasons. And the guy who was ahead of me 1 year in residency had gone to Carson City and was the only obstetrician in the community. And he kept trying to talk me into coming and joining him in his practice. And so we went and actually took over his practice for 2 weeks 1 year so he could go on vacation. And lived in his house and took over his practice and decided that would be a really nice place to practice medicine and raise a family. And there was certainly a big need there.
And you've been there ever since?
I've been there since 1976, yeah.
Tell me, when did you first get involved with the ACOG?
I got involved in ACOG in the early 80s.
What role did you have?
I got involved, kind of an unusual role. I was always interested in finance, and I had done a lot of reading on it and a lot of studying on it. And then in my small community, I kept seeing physicians who had very bad outcomes. They were being cheated by people who were calling themselves financial planners and putting them in investments with very high expenses or horrible investments where they lost all their money. And so I kind of started talking to the doctors in the community about it, and then I started kind of doing a little bit of a lecture series, and then I thought, gee, this would be a great thing for ACOG. So I asked to be put on an ACOG program. And at first I didn't get very far, but after a couple of years we had an ADM in Reno, and I was finally put on the spousal program, because at that time they didn't feel this was something doctors should be on a doctor program, and it wasn't, quote, scientific. So I did the spousal program, and the reviews were quite high, and all the spouses went to at that time most of the spouses were women, went to their husbands and said, man, you're the one who needs to hear this. So a few years later, after doing a couple more spousal programs, they put me on the main scientific program. Dr. Hale actually was the first one to put me on a scientific program at a district meeting.
Now that you've been active in that part, you've obviously gotten involved in the hierarchy of what made you get involved in that part of ACOG as opposed to the teaching?
Well, I became a section officer, and I worked up, I did this a couple of years as a section officer, and then the district officer position became available, and I applied for it and got it. And I just kept thinking there's more that could be done. And I tend to be pretty good at organizational matters and getting things accomplished, and I just kind of kept accomplishing things, and it seemed like it made more sense to keep going up. And I've always found it's better to run the meeting than be just at the meeting. Things get accomplished quicker and faster, and I'm not as bored. So it just kind of one thing led to another, and I had certainly an avocation, and very much want to be part of women's health care and improving women's health care in the nation. And the higher you get in the organization, the more impact you have on being able to do that. And improving care, coming from a non-academic private practice, one of the things that I pushed and was finally able to get done when I became a presidential officer was getting more order sets out there. That when I would go to some of these committee meetings, the committee members are brilliant people, but most of them were from academic institutions, and they didn't need an order set for X because they kind of had one for their institution. And I was saying that 60-70% of the deliveries are being done in smaller, less non-academic centers, and we're not that proud. We would love to know an exact order set for hypertensive crisis in pregnancy so that we don't have to make it up and keep it up to date and just have it there, because we don't have it happen that often. So at 3 in the morning, it's really nice to know that the dose of Labotal is this, and it should be repeated in this amount, and just give us these lists and set them up. And so I was the first one who pushed on that, and we got it, that first order set for hypertensive crisis in pregnancy.
Let me take you back to when you were district chair. We'll come back to the presidency later. But when you were district chair, you also made a number of changes in District 8 in terms of the things that we put into our scientific programs. Yeah,
I was very interested in, I guess at that time you'd call it wellness. Wasn't calling it that, but I wanted to get some things in on things like the Myers-Briggs, and so people understood themselves better. I've always thought that financial planning was a great source of burnout, that if you were financially secure, you didn't need to worry so much about that you were a better doctor and you were a better spouse and you slept better at night. If you were sure you could retire at some point and your kids could go to college. But some of the other things that I worked really hard on was getting more women into leadership in our district and finding positions for the young fellows. We were the first district to have a young physician on our advisory council. We were then the first district to have 2 young physicians on our advisory board. And I basically made those positions because we had some really top-notch junior fellows, and once they rotated out of that position, there really wasn't a place for them. And so the really good ones we found a spot for. And then the other thing we pushed really hard for was increasing the number of people we sent to the Congressional Leadership Conference. I thought that was really a good way to train our people to find out if they were interested, if they'd show up, if they'd do the work. And so we started funding that, and for decades now, we've had the largest contingent of any district at the CLC, and then they go back to their states and they could be very effective and active.
Having been a member of District 8 also, I remember very much the first time you had the Myers-Briggs test and the consternation from a lot of people in the audience of what are we trying to do?
Yes.
But it was innovative, and it was something that has been repeated now for many years by many of the districts.
Yes, I think it's been very helpful, and at the ACM that I ran, I had that too. I had some unusual speakers talking on the. We had someone do the Myers-Briggs test for people, which was a big hit, and then we had some other interesting lectures that I still have people come up and tell me how happy they were to have that. My goal at that time, and it was the same with some of the district meetings, was I want to have at least the 1 or 2 talks that were applicable to the doctor and the spouse, significant other, so that they were on the plane ride back home. They'd be talking about that and saying, man, that was cool. That was helpful. We should go back next year because that was a really good thing for us. And a number of people have said, how many lectures do I need to hear on HPV virus, and when someone all of a sudden gives me a lecture on how to interact better with my staff, my spouse, my children, and something that I didn't know and have never heard any other place. So I think it has had a positive impact.
I think your presidential program was a classic example of things that people need to know, but don't realize they need to know.
Yes, that's right. And I think they realized it when they heard it.
Yes.
Because a lot of beforehand people say, why are we hearing about this?
You've made a lot of major changes that have been carried on by others. What's your most disappointing factor? What disappointed you most during your presidency?
I don't think I had many disappointments. I was pretty free to speak out. It was a time when we really started speaking out because the public discourse had gotten so ridiculous. Politicians were making statements that were so unscientifically true that really hadn't been, people had lied and stretched the truth before, but we had people coming out with statements that were just absolutely off the wall. The classic example was the guy running for senator, Todd Akins, who came out and said if a woman is legitimately raped, her body will stop her from getting pregnant. Probably two words that should never be used in the same sentence, legitimate and rape.
Yes.
But, and people were believing this. And so speaking out and trying to, we started coming out when anybody made a statement that was scientifically incorrect, we would try to correct that and try to do it very quickly in the same news cycle so that it wouldn't get repeated and thought of as something that maybe we should believe.
It was during your presidency that we also increased the amount of involvement we had with the federal government.
Yes, and we were very active. I did a number of interviews with a number of different organizations, and we tried to be very proactive and tried to put women's health care in the best light. And we were certainly at that time, which was amazing to me, we were refighting the battle on contraceptive access again. And now my biggest disappointment right now, or that I grieve about, is now we're back to fighting that same battle. They're trying to take away contraceptive access as a covered benefit.
Now, you've been around ACOG a lot and have been in key positions and have been a decision maker. What would you recommend the one major change that ACOG should do today?
One major change? I think just continuing to be outspoken for women's health care issues and realizing they're not just specifically, I think we have a group now that wants us to say if this doesn't specifically relate directly to women's health care, then we shouldn't be talking about it. And I think we need to encompass, to me, immigrant health care impacts women tremendously. The gun issue impacts women. That's a homicide. Being killed in spousal abuse by a gun is a problem we have. So denying that, not saying that we should be speaking out on gun safety, because that's not something that we deal with or operate on or do something, I think is short-sighted. We've been doing that, and I think we need to keep doing that. But there's been some pushback by some of our members on that. But mainly making sure that we concentrate on what benefits women's health. As long as we keep pushing in that direction, I think we'll be doing fine.
Do you think, since you've been involved in the financial planning aspects and put on courses at the district section and national level, do you think this should become a routine part of all of our educational meetings?
Yes, definitely. That's something I keep pushing for. I think all district meetings should have at least one or two lectures on some type of wellness issue, whether it's the Myers-Briggs, whether it's the 7 Habits of Love, whether it's how to have conflict resolution, how to do difficult truths, financial planning. So financial planning is such a basic thing. Everybody should know it, and we're not educated on it, unfortunately. It's not part of the medical education, but we all need a certain amount of it.
I don't recall ever having anybody other than you ever teach it.
Yeah.
So, what do you see the future of our specialty now that you've been in it for a long time? Where is our specialty headed?
I think our specialty is headed to a kind of a bifurcation in most areas. I think that we're seeing more and more people becoming hospitalists and really enjoying that. I think that we're seeing more people going the minimally invasive route and getting advanced training in that. I think, as Ted said today, you can do everything, but it's hard to do everything well. I think, except in some rural areas, we're going to see people trending toward more and more subspecialization. There's so much to learn, it's hard to keep up with everything. The younger people that are joining our practice do want to work fewer hours, do want to be on call less, and so I think you have to look at the volume of surgery that's there, and if you're doing 4 or 5 hysterectomies a year, is that really enough to maintain competence in it?
You think those changes will take place, or do you think that's just something that's...
No, I think they are taking. I think they are taking place. I think we're seeing it. We're seeing it in the number of people who are becoming hospitalists and are just doing that as care. We're seeing that in some major systems. I mean, Kaiser Northern California is tracking people now. They give you 2 years to practice general OBGYN and pass your boards, and then after that, you have to either be a hospitalist, do outpatient with minor surgery, or be invited to do major surgery if you've shown an aptitude for it.
One of the things that you've seen all aspects of our specialty. What would you say to a young medical student who comes to you and says, why should I go into OBGYN?
Why not? Because you can do everything. You can do surgery, you can do outpatient, you can do obstetrics. I mean, there's just so much you can do. You can do infertility. I mean, if you want to subspecialize, you can do REI. I mean, we have the best of all worlds, I think, because there's so many options. And for the most part, it's a very joyful practice. Fortunately, most of the GYN cancers we can cure or prevent or catch at an early enough stage. I really dislike patients dying on me, so I find it nice not to have that. So certainly, you have miscarriages and you have stillbirths, and those are tragedies, but for the most part, those women are able to conceive and have a healthy baby after that, and so it's something you can work through with them. But I mean, there's a real joy I find in seeing a young woman and starting her on birth control and then delivering her baby after she's married, and then continuing to take care of her as she goes through menopause and into later life. And I mean, I've been doing this long enough that I've delivered, and I'm sure you probably were in that boat too, delivered daughters of people that I delivered, and even a few granddaughters of people that I delivered, and then delivered them and then their daughters. So you get that full continuity, you get to know your patients well. I find it just a very happy, fulfilling practice.
Thank you very much for coming to this. You have been actually a mentor to me.
Well, you've been a mentor to me too, I think more so.
But you've also had major impact on an aspect of our specialty. And I think coming from a private practice background, that's been excellent since, as you well know, for many years, ACOG was primarily an academic type institution, and it's important since most people are in practice.
Yeah, I've heard a few people come up to me over the years and say, man, if somebody from Carson City can be president, anybody can be president.
Yeah. So. Well, you were an excellent president, and I thank you very much for coming to interview with us and share your ideas for the future.
You're most welcome.